ثانك يو. طبعا لازم اشكر استاذتي دكتوره امال بشلاوي انها اتاحت لي الفرصه، ولازم ابارك لها على المؤتمر. الحقيقه يعني من محاضره لمحاضره كله احلى من بعضه، وصعب قوي ان انا اتكلم بعد كل الزخم ده من المحاضرات العلميه القويه ومع كل الاساتذه اللي سبقتني. وطبعا عارفه حضراتكم الهايبوكافينيميا ابتدت لان احنا اليوم طويل، فمعلش يعني استحملوني شويه صغيره وان شاء الله هخلص، بس مش 17 minutes يا دكتور احمد. My topic عن management of hereditary pseudo hemophilia. I would start by my disclosure and the agenda. I would start mainly basic, talking about the hemostasis, and I will go through the von Willebrand and its diagnosis, comparison between the von Willebrand and the hemophilia, diagnosis of von Willebrand, treatment, guidelines, and I would end by the Egyptian registry as was previously presented by Professor Sonia Adolf. I will start by the hemostasis. When an injury occurs, the vessel contracts in order to limit the blood supply or the blood flow to the site of injury, and this happens with the help of von Willebrand because it acts as a glue that helps in such part. And then afterwards, the primary hemostasis, where the platelets start to form the platelet plug, and ending by the secondary hemostasis, where the cascade we all are well oriented of, and formation of the stable clot and the deposition of the fibrin. So what about the von Willebrand? What does it do? Usually it's produced and it's stored and it's released in the site of injury. It mediates the platelet plug formation and it stabilizes factor 8 in the circulation. It prevents factor 8 from its fast clearance by the liver. So what's the first presentation of von Willebrand, or how does this name come from? Let's go back to history, and I'll start by just the definition that von Willebrand is deficiency or defective qualitative defect in the von Willebrand factor, resulting in delayed defective platelet adhesion or delayed defective platelet plug formation or even delayed defective fibrin clot. And this was first presented بما ان احنا بنتكلم عن الثلاسيميا, وال first description of thalassemia was in 1925 by Dr. Lee Cooley. فاحنا هنا von Willebrand كان a year بعديها 1926 by Dr. Eric von Willebrand. He's an internist from Finland, and he described this disease based on patients from an area called the Gulf of the Bothnia, which is an area between Finland and Sweden. It's even more or less 50-50 between both countries. And this was the first description. At that time, it was called the pseudo hemophilia. And from here came the initial terminology, after which it was termed von Willebrand. And the first case who he described was a young girl with repeated bleeding episodes. The bleeding were from the gum after tooth extraction, from the lips, nose. These were the main manifestations. It started at the most severe ones. Attacks were the attack at the age of 3 years, where she had a cut wound in her lip. And this cut wound was not resolving, and she kept bleeding, that she was unconscious and she couldn't leave the bed for 10 weeks. Afterwards, at the age of 5, she had bleeding from the nose, and then she died by the age of 13 after her 4th menstrual period. The family history was she's coming from parents with both parents had come from families with bleeding history, and there were 7 of the children had history of bleeding, and 4 females died from uncontrollable bleeding. And what about the prevalence? This I see that this slide is very important because von Willebrand is the most common inherited blood disorder, and with a prevalence of 1% in the general population. From this, we feel that there's a lot of underdiagnosis of this disease. Lots of bleeders are there everywhere, and we're not diagnosing them. So this is something that we have to point out, because it has been mentioned that in different population-based studies that around 0.1% of patients attending a primary care clinic experience medically significant symptoms of von Willebrand. So bleeding is there, but sometimes lots of them are not diagnosed. But von Willebrand is an entity that needs more highlighting to the importance and the spread of the disease everywhere. And as decreasing the concentration would definitely increase the bleeding risk. And we either have a quantitative, a decrease in the von Willebrand, or a qualitative, which is defective in the function. The types, as we all know, it's either type, there are three main types or three main categories. Type 1 and 3, these are the ones related to the quantity, meaning decrease in number. The type 3 is severe deficiency with a moderate to severe deficiency of factor 8, while type 1 is the deficiency decrease, but up to 30% of the normal factor level, while the type 2, it varies, it's qualitative, meaning varying the platelet attachment or binding to either to the platelets or binding to factor 8. So it's the qualitative defect in the von Willebrand factor itself, with the surrounding, whether platelets or factor 8. And if we just go through them so quickly, the type 1 is the commonly present, around 60 to 80% of the cases, and it is autosomal dominant. But thank God it's mild, and the bleeding is not that severe. The most severe type is type 3, which is autosomal recessive, and the bleeding is severe, while type 2, it varies, but still it is either autosomal recessive or autosomal dominant, and the bleeding is moderate. So what's in comparing hemophilia to von Willebrand? Hemophilia, as we all know, it's an X-linked, so we usually find it among male, while the von Willebrand, it's present among both sexes, whether male or female, and the hemophilia, either deficiency of factor 8, causing hemophilia A, which is 1 to every 5,000 cases, male birth I mean, or deficiency of factor 9, which is 1 in every 30,000 male birth. While von Willebrand, as I previously mentioned, it's almost 1% of the population, accounting for 23 to 100 cases per million population. And it's resulting from a deficiency or defective function of the von Willebrand factor. As we all know, that the main problem with thalassemia is the musculoskeletal systems, whether the joints, mainly the joints, affecting about 70 to 80% of the cases. Joints are highly affected, followed by the muscles, and then other parts like the intracranial hemorrhage, which is might occur. But in case of von Willebrand, it's more common in the GIT, in the mucosa, oral mucosa, and nasal epistaxis, menorrhagia. These are the commonest, accounting for the major bleeding, mainly mucous membrane bleeding, which differs than the hemophilia, but in addition, bleeding can occur also in joints. And many patients with the disease have not been diagnosed, as I previously mentioned. Lots and lots of cases are there, but still they are not well taken care of. So how can we diagnose? The diagnosis has to pass by 3 steps, mainly the history, the differential diagnosis, and then the diagnosis of von Willebrand. History is very crucial because thorough history taking is a must, going through the individual clinical history. Family history is very, very, very important, and personal history about previous bleeding attacks throughout life. And I would like to put this quote by the Sir William Osler, the father of modern medicine, where he says, you have to listen to the patient because he's telling you the diagnosis. So this points out to the importance of history taking in any case, and in the cases of von Willebrand, definitely it would much help. History taking would include asking about different parameters of bleeding, like for example, bleeding, whether the personal history or from family history bleeding during surgery, during childbirth, after trauma, bruising with lumps, or having any blood disease, liver disease, taking medications like aspirin, warfarin, all these are very important in history. And to ask about history of other medications, if the patient is taking medication, desmopressin, any family history of similar conditions, and if the history, we did not find anything, then nothing else. If any of the history taking is suggestive, then we ask more leading question, and if still we didn't get any answers from the history, then we can consider nothing. But if we get any clue from the history, then laboratory diagnosis is a must. So what are the main tests to decrease the differential diagnosis? We do the very basic platelet count, blood smear, prothrombin time, partial thromboplastin, bleeding time, and then we measure the von Willebrand factor once everything else has been ruled out. And type 3 and type 2 are relatively easy to diagnose, but type 1 is a bit problematic. These are the different tests for the subtypes. I would not go through them, whether the antigen, the ristocytine, factor 8, the ristocytine-induced platelet aggregation, and platelet count, von Willebrand, but each one is specific according to the type of 2, and the differential diagnosis is wide, and you can find it out from this table. So what about the clinical? We are all clinicians, and we care about the clinical outcome that we see. The main bleeding parts are the mouth and nose, the joint bleed, gastrointestinal, and the menorrhagia. The commonest, as I've previously mentioned, the type 3 is the most severe with the clinical findings, the highest percentage of clinical finding with the menorrhagia, GIT bleeding after tooth extraction, and then other types would be on a lesser extent. What about the gastrointestinal angiodysplasia? This is something very common. It accounts for 10% out of the von Willebrand patients, and it may be related to the anti-angiogenic properties of the von Willebrand, and it's usually patients with type 2 or 3 are most susceptible to this GIT bleeding, and this is an indication to give prophylaxis in such cases. What about the joint bleed? The joint bleed varies. It's as we all know, the joint bleeding in hemophilia, and when this is severe joint affection is also an indication for prophylaxis. So what about the treatment? The treatment strategies is based upon 3 main items: elevating the endogenous von Willebrand in the bloodstream, or replacing the deficient factor, or promoting hemostasis and wound healing. These are the 3 main aspects that we deal with among those patients. If we're talking about elevating the level of von Willebrand, usually this is based on using the commonest drug known is the desmopressin, and it's usually effective in type 1. And it's a bit efficacious in type 2A and 2M, and not indicated in 2B and 3, as it might lead to major complications of thrombocytopenia and cardiac problems. Replacing the deficient factor by giving the replacement by factors containing the von Willebrand factor. Promoting hemostasis and wound healing by the antifibrinolytic drugs and the topical agents. After which happened in thalassemia, برضو الدسفرال was mentioned later in the late 60s and 70s after the first description of 1925. So this is the timeline of the development and all therapies for the von Willebrand till we had the FDA and the EMA approval for the drugs and up to the recombinant von Willebrand factor. What about guidelines? احنا اغلبنا بنمشي على الامريكان الASH guidelines. So this was the ASH guideline presented, and the title was Rediscovering an Old Disease. and they mentioned the use of the antifibrinolytics, tranexamic acid, كلنا بنستعمله. Tranexamic acid is commonly used for mucosal bleeding in the patient, and we can use it in addition to desmopressin and in addition to replacement therapy by factor containing von Willebrand. And there are different methods of using it. The adverse events include mainly GIT, nausea, vomiting, abdominal pain. These are the main concerns, and it's better avoided in cases of hematuria or renal problems. What about the desmopressin? Desmopressin, it's important because it causes the release of von Willebrand and factor 8 from the endothelial cells, and there are different forms. هو طبعا احنا في مصر دلوقتي ما بقاش عندنا غير التابلتس، بس هي المفروض ان هو بيستعمل by different forms في nasal, subcutaneous, the IV line, or these are the routes for administration. The adverse events include hypotension, hyponatremia, and up to seizures. So it's better avoided for children under 2 years and for patients with cardiovascular disease. What about the plasma-derived factors containing von Willebrand? There are lots of them have been described throughout the years, but it's very important when choosing a replacement therapy is to choose the factor that contains the optimum amount of von Willebrand in order to treat the conditions that the patient is suffering of, to supply the deficient factor needed. As you can see, these are the different approved replacement therapy for the von Willebrand deficiency, and I would just be mentioning the Immunate. The Immunate, with its different concentration, has a well-known amount of von Willebrand. It's important when calculating the replacement therapy to know the concentration of the von Willebrand in each factor. I mean, in each concentration, the 250 or the 500, you have to know the amount of international units of von Willebrand in each concentration. For example, in the 250 unit, you have 190 international unit of von Willebrand. In the 500, you have 375 international unit. The 1000, it's 750 international unit. So this would simplify things while calculating replacement in case of deficiency. What about the recombinant von Willebrand factor? There has been approved, but still we don't have it in Egypt. And the problem with it, it does not contain factor 8 at all. So what about the clinical management? The guidelines has been through all types of bleeding, whether menorrhagia, GIT bleeding, severe bleeding, acute bleeds, surgery, and it has emphasized the importance of multidisciplinary team. And from here, I need to ask about having a working group. We need to go to the gynecologist, the surgeons. They have to know all about bleeding, especially in women, because lots of cases that might be not discovered, like type 1, might not be discovered, like the heterozygous form of type 3 might not be discovered easily. So it's important to have multidisciplinary team in order to face this disease and to diagnose early as possible and to initiate treatment as early as possible. This is according to the ASH guidelines in different situations. What do we use? And it emphasized the importance of using several therapies, like the replacement with tranexamic acid, replacement with desmopressin. So you have to move every step in a chronological way in order to control the bleeding. And even lots of therapies in cases of acute massive bleeding that we have never thought of. I would like you all to go through this publication because I found it highly informative. This was the ASH, the ISTH, the NHF, WFH 2021 guidelines on the management of von Willebrand. It goes through all the guidelines and what's the pros and cons, and it's very informative الحقيقة. And the main recommendation was in patients with severe frequent bleeding need long-term prophylaxis rather than no prophylaxis. This is the main issue in the recommendations. And I would end by the von Willebrand disease incidence among patients with bleeding manifestation from multi-hemophilia treatment centers in Egypt, data from the von Willebrand registry. This was it was a work in Egypt among different 15 centers, والحقيقة ليا الشرف ان انا شاركت فيه. This was presented by Professor Sonia Adolphe في الإيها في الإيهاد last إيهاد، وكانت والWFH كمان المرة دي لأن الريجستري كان the last number 2018 was 583 و I think now احنا 655 مش كده يا دكتورة سونيا؟ I think 55 ف I think this work it was an extensive and fully integrated country program led by the Egyptian Society of Hemophilia, وكان الايم بتاعها to enrich the national registry to improve diagnosis and management of von Willebrand patients و to increase awareness. طبعا انا I'm not gonna go عشان برضه الوقت عشان دكتور احمد ما يقولش حاجه. انا بس حابه ابوينت اوت لحاجه ان هو كان 294 عيان السكرين 52 منهم طلعوا von Willebrand which is accounting for almost 18%, but still there were other cases. يعني في cases اتشخصت زي الهيموفيليا الترامبستينيا و if we go through the different types of von Willebrand يعني 25% كانوا type 1. بس انا حابه حاجه بس to mention هنا كان في one patient كان carrier او heterozygous for type 3 و this point out to the importance of carrier detection لانها قد ايه احنا ممكن نقدر نعرف في الفاميليز ونقدر نشخص من بدري الحالات الكتيره اللي بقت under diagnosed وبتبقى بتمانيفست بعد كده بمينوراجيا و severe bleeding في critical situations لو واحده في child birth او كده. ف it's very important to early diagnose these cases. And مش هقدر اقول اكتر من ان هو ان التايب 3 is the commonest وسببه increased الهاي consanguinity rate ومهم قوي ان احنا نديتكت الكاريرز as early as possible. بشكر حضراتكم على حسن الاستماع.
شكرا.